Yeah, good afternoon, ladies and gentlemen. Thanks to GVK sir. This is my topic, painful neuropathy. This is a very basic slide, like where you see the kind of different types of nerves, the motor and sensory nerves and autonomic nerves. It's very simple that many times the diabetic patients, they do get a lot of sensory symptom. That is because most of these nerves are they are having some kind of unmyelinated, so it's unmyelinated or thinly myelinated, whereas motor nerves are thick and they are myelinated. So that's the reason why you get more often these kind of the glycemic excursion and oxidant injury, reactive oxygen injury, all these kind of thing like a chronic inflammation that can lead on to small fiber neuropathy. So these fibers are otherwise called the C fibers. They carry most of the time the nociceptive information, that is pain and heat. So that's why many of our patients, they do feel some kind of dysesthesia, the burning type of pain, lancinating type of pain, pricking type of pain. These kind of thing are more common in such individuals. That is because of the involvement of the sensory nerves, which are either unmyelinated or thinly myelinated. So we know that 8% of the diabetes, they can have peripheral neuropathy at diagnosis, and over a period of time, depends on the duration of the diabetes, more than 50% of the patients, they can develop this neuropathy. Of course, put the patient on a lot of the morbidities like deformity, foot ulceration, neuropathic pain and so on. So I'm going to talk about a little bit on the neuropathic part of it. But before that, this is a very important slide. So whenever a patient is having a hyperglycemia, it can go to several pathways. So one such thing is through the aldus reductase pathway. It can get converted to the sorbitol and it decreases the nerve growth factor and can result in neuropathy. So people have tried a lot of aldus reductase inhibitor, but it all unsuccessful. So the other pathways were the exosomal pathway and protein kinase pathway. Again, people tried a lot of PKC inhibitor and other things to mitigate the oxidative stress. Again, end up with failure. So this is a kind of thing where the patient who are having a long-standing diabetes, they are at risk of developing neuropathy over a period of time. So there are some signals about these, the changing concept with regard to the diabetic neuropathy. So we all know that the mitochondria is one thing which can convert, utilizes glucose and lipids and converts the NADP and FADP to ATP. So this we all know that. So that what happens in patients with diabetes is there is a bioenergetic failure happens, because of which despite glucose, there is a disruption of the electron transfer, these NADP and FADP, which can result in increased accumulation of the reactive oxygen species. And as a result, small fibers again are at risk of vulnerable to develop a neuropathy. So this is characteristically, it occurs in a distal to proximal fashion, so which we all clinically we see. So this is a chain. So not only the diabetes, but also the kind of hypertension, dyslipidemia, obesity, all these things which results in bioenergetic failure and decreased utilization of these ATP and resulting in axonal failure and neuropathy. So what are all the risk factors? So we do have a lot of risk factors, of course, hypertension, dyslipidemia, obesity, all these things. Remember that these things are again a cardiovascular risk factor. Of course, the duration of the diabetes, the alcohol, patients with low socioeconomic strata are some of the risk factor. So this is a thing which we are looking at is the peripheral neuropathy or painful neuropathy. So not only the control of the blood sugar, but also the control of the metabolic syndrome, which we are aiming at with the recent literature, with the recent literatures available. And another thing is the exercise, which has got a moderate evidence of benefit to all our patients with neuropathy, particularly the supervised exercise, the aerobic exercise, weight training exercise, balance exercise. So these things are very much important under supervision for these patients. Of course, the recent ADA also has given a lot of emphasis on these the exercises under supervision. So coming to my topic proper, so I have given you an overview of the diabetic neuropathy. This is acute painful diabetic neuropathy. So this still we do see in up to 8% of our population. This form of sensory neuropathy is quite moderate to severe. Typically, we do see these kind of cases after the normalization of the glucose. Many patients comes to us after they get optimal levels of blood sugar. They come and say that they get neuropathy symptoms are getting worsened. And this can also follow a DKA, more common in females, more common in people with eating disorders. Of course, the prognosis is good and it's self-limiting. It may last for 3 to 6 months, maximum up to 1 year of time. Previously, it was called insulin neuritis. Now, the terminology is treatment-induced neuropathy of diabetes, because insulin is not only the cause, there are other things are also there. Coming to the common form which we see in our clinical practice is another presentation of this painful neuropathy, which can present with lancinating pain, dysesthesia, pricking type of pain, burning sensation, particularly worsening at night time, involving the lower limb. Sometimes it can involve the trunk, and patient can present with ANS features also. This is again quite common in patients with weight loss and on patients who are on diabetic treatment under control. Now coming to the pharmacotherapy, there are very few drugs which are available to treat this painful neuropathy. One such agent is pregabalin, which acts on the calcium channel alpha subunit ligand. The dictum is we need to start slow and low. Start with BD dose to we can up titrate to TAD dose. Of course, 300 to 600 milligram is the maximum tolerable thing which we can go for. These drugs are excreted unchanged in the urine. So we need to exercise again some caution when the patient is having a eGFR of less than 45. Of course, these patients who are on pregabalin, when we step up the dose, they are at risk of developing somnolence, drowsiness, and pedal edema, particularly with a higher dosage, and in patients who are elderly. The practical thing what we can do is most of the symptoms, they occur only at evening or night time. We can do the asymmetric dosing. So we can give 75 milligram in the morning and 150 milligram at evening time. So this asymmetric dosing can be done. And of course, it does have some anxiolytic actions which can benefit patients who are anxious. The next one is the selective norepinephrine serotonin reuptake inhibitors. Of course, venlafaxine is not not indicated for treating painful neuropathy. So this duloxetine is a very good drug, which is available as once daily dosage. The maximum tolerable dose is 60 to 120 milligram. Of course, it does have some similar efficacy. It can be combined. It can gel with pregabalin also in patients who are not responding. Of course, it also produces some kind of somnolence and dizziness. And in addition, it does have some antidepressant activity, which can benefit patients with depressive symptomatology. The third one is amitriptyline. It's an age-old drug. It's a good drug, but we need to be cautious about its side effects. That is dry mouth, urinary retention, and drowsiness. We need to exercise caution in patients with ischemic heart disease and in patients with glaucoma. We can start with 10 milligram or 20 milligram, and we can escalate it up to 75 milligram. This is another anti-epileptic drug, which has got a shorter half-life, since can be given thrice daily. Again, you need to exercise some caution in patients with low GFR. The opioids, it has got varying actions. Tramadolol still can be used. And paradoxically, the naltrexone also can be used as given in the recent literature. Generally, these drugs, we can start with pregabalin or gabapentin. Then we can add up the SNRI. The TCA comes as the third line of agents. The opioids, again, comes a little bit later. The duration of these drugs to treat painful neuropathy, it varies. Generally, it's usually up to 6 months of duration. The other group of drugs are topical nitrate and capsaicin, which should be given repeatedly, and sometimes it can cause unpleasant burning sensation that one has to keep it in mind. Of course, these are all other things, SCS, FRAMS, stents, and NMS, or other modalities to treat patients with painful neuropathy. Of course, much is being discussed by Dr. GVK about the nutraceutical products. So, ladies and gentlemen, this is a very commonly prevalent chronic complication of diabetes. One has to screen for these patients. Of course, I didn't dwell much on the screening part of it because my topic is on the management of painful neuropathy. Early diagnosis is more important, not only the blood sugar, the other parameters, hypertension, dyslipidemia, weight loss, and graded exercise under supervisions are very much important to treat these patients with painful neuropathy. Of course, it needs some multi-level management and the treatment should be individualized. Thank you for your attention.